Okay, Assalamualaikum warahmatullahi wabarakatuh to all my year 2 students. Okay, welcome back to the class, our virtual class of dental public health. Okay, so I think this is the first lectures after after 3 months of leave. Alright, so I hope everyone feel quite motivated, alright, after these long holidays. Alright, so as for today, I would like to refresh back, okay, what is dental caries is all about. Dental caries, and as for this title, it's about the internal and external modifying factors that involve in dental caries. Still remember what is dental caries? Okay, so dental caries is a common disease in dentistry. It can be preventable, okay, but some of the factors is beyond our control. So dental caries is due to when there is a plaque that form on the tooth surface. It converts the free sugars that contain in our food and drinks into acids. Okay, this acid will dissolve the tooth enamel and dentin over time. And it's very complex multifactorial disease. Okay, it's interaction between tooth structure, biofilms, dietary carbohydrates, salivary, and genetic influences. Okay, there is many factors that may modify the prevalence, the onset, and progression of the dental caries. Though such factors can be divided into internal, endogenous factors, and also external factors. Okay, this is a figures that modified from the Fajerskov and Menji 1990s. It's about the relationship between etiologic factors in dental caries. So there is internal factors, the external factors. Okay, you may have look at this. Okay, the tooth, the plaque, okay, the saliva that around the tooth, and the other factors that involve. So the objective of these lectures, actually we want to explain the role, okay, at the end of these lectures, you should know how to explain the role of internal and external modifying factors in development of dental caries. And also you should be able to discuss about the subject with evidence from the epidemiological studies, okay, means that from the previous studies. We start with the internal modifying factors. Okay. There is a lot of factors that involve. Okay. However, this is we choose the primary factors only. So I talk about the saliva, the chronic systemic disease and impact host factors, also the tooth size, morphology, and its composition. Okay. So for the saliva, normal daily volume that produced by the salivary gland about 0.5 milliliter to 1 liter. Okay, the saliva itself. So only 2 to 10% produced during sleep. It's quite low during sleep. And about 80% is stimulated by chewing. Okay, when we chew, when we eat, the saliva production is become stimulated. Okay, and about 90% of the total volume is produced by 3 pairs of salivary glands. Okay, 3 major pairs, which is the parotid gland, submandibular glands, and also the sublingual glands. Okay, what is the function of the saliva? Okay, saliva it serves as a first-line defense in oral cavity against infectious disease, erosion, attrition, traumatic lesion. Okay, So saliva also have other functions in protecting the integrity of the oral cavities. Okay, so some of the function is for buffering effect against strong acid and base. Saliva also provides the ions that needed to remineralize the teeth. Saliva also has antibacterial, antifungal, and antiviral properties. So the component of saliva also is facilitate our motor function for chewing, for swallowing, for speaking, and the other function in the oral cavity. So this is the major function of saliva. So as for protective function, okay, it's also function as a lubrication. Okay, this is the component. Okay, you may see the component at the right side, right hand side, and it's also function as antimicrobial, the cleansing, the buffering, remineralization, okay, for the digestion, for the tooth, and for the taste, for the speech. Okay, so now we talk about the salivary secretion rate. So how much the rate of the production? So when I say the whole saliva, the fluid that present in our mouth is comprised of the whole secretion from the major, from the minor glands, also from the crevicular fluid, from the food debris, and all that. Okay, so this is the value of the unstimulated and stimulated whole saliva. It's by milliliter per minute. So you can see here for the normal values for the unstimulated is about 0.25 to 0.35 only. Okay, and once there is a stimulation, okay, it can up to 1 liter to 3 liters. Okay, however, this is for the normal. Okay, for this is for the normal production. Once there has a hyposalivation or reduce in production of saliva, it become lower. For the unstimulated, it's less than 0.1 milliliter per minute. Okay, and for the stimulated, it's about less than 0.7. So we can check. Okay, we can check our own version for this reason. Okay, so what's the symptom of the salivary gland hyperfunction? Because once there is a hyperfunction of salivary gland, it results in hyposalivation. So apart from increased susceptibility to caries, okay, there is other oral and systemic disturbance associated with hyposalivation. Okay, so one of the symptoms, okay, the dry mouth, xerostomia, dysphagia, dysphonia, difficulty in wearing dentures, okay, burning sensation, abdominal taste sensation, okay, fissured tongue, and there is a sores at the corner of the lips. So it's a sign and symptom of the hyposalivation. And there is also non-oral symptoms associated with salivary gland hyperfunction. It's like the dry throat, dry skin, blurred vision, okay, constipation. So we would like to know what's the causes, okay, causes of hyposalivation. As we know that salivary gland derive their fluid from the circulating blood. Okay, so when there is a disturbance of the blood supply to the gland, or not enough stimuli, so it leads to decrease in the saliva production. So the principal causes of salivary gland hypofunction and xerostomia is a drug or medication. Okay, for example, the analgesic, antihistamine, antihypertensive, diuretic, and etc. And there is, if patient undergone therapeutic radiation also, particularly to the head and neck area, they would have a problem with the salivary hyperfunction and xerostomia. Okay, and the other diseases also, for example, rheumatoid condition, Sjogren's syndrome, menopause, and when there is a stone in the salivary gland and aging also can produce the hypersalivation. So the principal properties of saliva that protect the teeth against caries are it dilute, okay, and clear the dietary sugars. It also neutralize and buffer the acid in plaque. Saliva also supply of ions for remineralization. Okay, so it's also both endogenous and exogenous anti-plaque for the antimicrobial factors. Okay, the second modifying factors is chronic systemic disease and impact host factors. So the greatest caries risk is associated with the rheumatoid condition. For example, the Sjogren's syndrome, severe depressive effect on the salivary secretion rate and quality of saliva. Cariogenic disorders, allergies, hypertension, etc. also regarded as risk factors because of the associated long-term medication. When patient taking the medication for this systemic disease, it will affect on the salivary production and rate. Leukemia patient, diabetes patient, Down syndrome patient also associated with the hyperfunction. Okay. Our soft and hard tissue of oral cavity protected by immune factors, okay, which it limit the microbial colonization of the oral surfaces. It also prevent the penetration of the substance and damage to the underlying tissues. So the non-specific immune factors in saliva, for example, the lysozyme, lactoferrin, antibacterial compound, etc. Okay, this is IgA and IgG. What is IgA? What is IgG? It's not the Instagram, okay? Alright, it's the immunoglobulin. Immunoglobulin, the immune factors. Okay, our immune factors. So this IgA, IgG is protect our tooth surface. So how is it affects? It by inhibition of bacterial adherence. Bacteria is hard to attach to the tooth surface. By blockage of the bacterial adhesin, by reduction of bacterial hydrophobicity, okay, it inhibit bacterial enzyme. Okay, there's so many effects of the immune factors, immune system. Okay, next is the role of tooth size, okay, morphology and composition. So the physical characteristic of the teeth also may increase the risk of for caries. Okay, what is the physical characteristic? For example, the tooth size. Okay, the tooth morphology. Okay, the anatomy of the tooth, the cups, the fissure patterns, the enamel structures, whether there is a defect or mottling or any opacities, morphology of CEJ, cementum enamel junction, expose of root surfaces. Okay, this is all the characteristic that may increase the risk for caries. So the plaque will retain. The retention of the plaque is enhanced by the presence of deep buccal pit. For example, if you can see here, okay, I circle here. Okay, this is a buccal pit. When there is a deep buccal pit, there is some plaque retention over there. Okay, that's why when it's left without brushing over there, it can cause dental caries. Okay, lingual pits, okay, at the lingual site. Barrel-shaped incisors, okay, when there is quite, it's like a barrel, okay. A deep palatal groove, okay. This is a caraballicaps, okay. And this These morphologies will enhance the plaque retention. So the tooth morphology of the tooth it maybe give a hint to us to decide the tooth whether it need fisher sealant or not. Okay. So next is dental biofilms. What is dental biofilm? Okay. So dental biofilm is the foundation of dental plaque is begin when the formation of a cellular organic pellicle on the exposed tooth surface. It means that after you brush your teeth, okay, after 30 to 1 hour, okay, a few minutes only, the clean tooth, it will adhere with the protein film, okay, from the saliva. So this stage we call a pellicle. Okay. This is the start. This is the start. When there is a pellicle formation, it's the start for the dental plaque formation. Okay. So the pellicle will form rapidly whenever a clean tooth surface is exposed to saliva. Okay. So the function of this pellicle is actually to protect the tooth surface from the abrasion, from the grinding force during mastication. Okay. Okay. So when you see this, this is the figures and how the stages in plaque, dental plaque formation. It start from the pellicle. Okay, here we start from here. So pellicle attached at the tooth surface. Okay, this is the enamel surface, and there is a pellicle. After a few hours, 0 to 4 hours, it's about 0 to 4 hours, there is a single colonization. Okay, single bacteria will come into the tooth surface to make it a colony. Okay, one bacteria, one microbe only. So from one bacteria become microcolony within a few hours only. Okay, it grows, it colonizes, it grows, it become microcolonies. There is some group of bacteria, this is some group of microbe, and so that. From the microcolony is macrocolony. It become growth and proliferate. Okay. Within this stage, okay, within this stage, the bacteria become more aggressive. Right. From the Streptococcus mutans, it changed to the actinomyces, for example. Okay. From the attachment to the maturation of the dental plaque, it only take about 2 weeks. Okay. Within 2 weeks, the plaque already matured. Okay, once it's matured, it's quite hard to remove by brushing only. Okay, so within 2 weeks, if the dental plaque is untouched, if the patient didn't brush their teeth properly, the plaque is stay at the tooth surface, so it become matured. It's quite hard to remove. Now, I will talk about the external modifying factors in dental caries. Okay, we already covered about the internal factors. Okay, the saliva, the tooth itself, and the systematic of the host. Okay, systematic disease of the host. Host here, ourselves lah. So for the external modifying factors in the dental caries, the role of dietary factors and some other factors. Okay, so frequent consumption of food and drinks that contain fermentable carbohydrate, which is sugar, is associated with dental caries. So the risk factors for caries in children less than 6 years is related to the consumption of sugars. It's not only less than 6 years, actually for the whole is for anyone. Okay, so the risk factors for dental caries is amount, the frequency and timing of the consumption. So the frequency of intake and total sugar consumption is important for caries development. Therefore, it's reasonable to encourage a reduction in both frequency and total of sugars. So this fermentable carbohydrate is ranked in order of complexity. All of this carbohydrate, it can be fermented to acid by bacteria. So we start with the monosaccharides, glucose, fructose, disaccharide, sucrose, maltose, polysaccharide, gluten, and fructan and starch. So, okay, we look at. So, I would like to share about the traditional studies here, the evidence from human, longitudinal, interventional, and experimental studies. Okay, this is a traditional studies, a classic studies. If you want to talk about the sugars, you should know about these three studies: Whitehorn study, Turku study, and Stephen Curve study. Okay. There is a different study, a different research. Okay, so we flashback, in 1954, this study have been conducted by Whitehorn, by the Gustavsson et al. 1954. Okay, so this is quite unique study of all caries research. Okay, the researcher have total control over the amount and the frequency of the sugar ingestion. It's conducted in Sweden over 5 years period, from the 1946 to 1951. Okay, the aim of this study is to study the relationship between the sugar intake and the caries activity. Okay, by varying the cariogenic substrate, okay, the amount of sugar, the form of sugar, the frequency of sugar intake, okay, whether it's only at meal or between meals, okay. So the sample is about 436 institutionalized and mentally handicapped or retarded adults. That's why it's quite controversy study, because there is no ethical. Okay, for the ethical study, it should not be for the mentally retarded patient. Okay, patient must give a consent. Okay, patient must give consent to join, to participate in the study, but not for this study. That's why it's quite unique and classic. It's not ethical. So, however, we learn from this study. Okay, Whitehorn study, they established 7 different groups. Okay, from the 436 sample, they divide into 7 study group, which is the control group, the sucrose group, the bread group, caramel group, okay, 8 toffee group, 24 toffee group, chocolate group. Okay, so there's so many studies within. Right. So for control group, they give a low sugar diet only at meals. For the sucrose group, they give high sugar diet, mostly drinks at meals. And bread group, sugar intake either half or normal, only in sweetened bread at meals. For the caramel group, they given 22 sticky candies, 2 portion at meals or 4 portion between meals. Okay, and then for the 8 toffees, they given 8 toffees in 2 portion at meals and 4 portion between meals. And for 24 toffees, allowed to eat 24 toffees, okay, throughout the days. Chocolate group, they given milk chocolate in 4 portion between meals. Okay, so there's so many. So the result, this is the findings from this study. It shows the relationship between sugar intake and the caries incidence. Okay, so you can see here, This is the DMFT of the patient and also the duration of the study. You see the highest group that having caries experience is the 24 toffee groups. So the sugar consumed, okay, sweet drinks or in bread at meals, okay, had only little effect. Okay, this is the conclusion. The group that receiving chocolate 4 times daily between meals, having the moderate increase caries. And the dramatic increase occurred in groups that receiving 22 caramels, 8 toffees or 24 toffees between and after meals. So we can see from here, okay. So the conclusion of the study, even we consume in large quantities, is associated with a small increase in caries as long as it is limited to meal time. Okay, so the intake of sugar between meals and at meals is associated with a marked increase in caries incidence. The caries activity also subside once sugar-rich foods are withdrawn from the diet, and the caries incidence varies from person to person. Okay, there is a second Turku sugar study, the classic study from the Shinen and Mäkinen 1975. It's conducted in Turku, Finland over 2 years period. They aim to study the differences in the caries increment as influenced by various sugars. The subject is about 125 subjects. The trial involved almost complete substitution of sucrose, fructose and xylitose during a period of 2 years. So there is a clinical examination conducted throughout the study. They are also taking a 2 bite wings radiograph each side of the mouth. The pre-cavity and also cavitational lesion were recorded for primary and secondary caries. Okay, so this is they divide into sucrose group, 35% in the sucrose group, fructose group 38%, xylitol 52%. Okay, this is the bite wings. The result, okay, 24 months, 2 years, caries incident. The primary caries only. Sucrose, for the sucrose group, DMF, the score for the caries is about 7 decade, 7 decade. Fructose group is about 3, xylitol is score 0, means there's no caries. Okay. The result is a massive reduction of the caries incident in relation to xylitol consumption. The X diet, okay, the X diet and xylitol was clearly less cariogenic than either the sucrose or fructose diet, but it cannot be concluded that the F diet was less cariogenic than S diet. The anti-cariogenic properties of xylitol principally depend on its lack of suitability for microbial metabolism. Okay, for the third study is from the Stephen 1944, or we call the Stephen curve. Okay, so when microbial deposits are exposed to the fermentable carbohydrate, for example sucrose, for a short period of time, the pH, okay, will fall rapidly. So this is the study is talk about the pH, pH value, whether the acidic or the alkalic. The pH then gradually rise, although not as rapidly, and the baseline level is resumed within 30 to 60 minutes. So the severity and duration of the fall in pH will depend on the developmental stage and age of the plot. So from this figure, Okay, it represents the change of plaque pH over a period of time. So just imagine, okay, this is the graph. This is the pH level, the y-axis pH level. So this is the duration, okay, the time. Our the natural value of pH is 5.5 here. Okay, here is the natural pH, okay, 5.5. So for example, we start from the morning, okay, we take a breakfast in the morning at 7 a.m. So our normal pH we drop, okay, from here it drop down here, okay, it can up to 3.5. It's very acidic, okay. So this is when there is a food debris in our mouth. Within 30 to 60 minutes, okay, within 1 hour, the pH become neutralized, okay, in natural to 7. Alright. So after that, we take lunch around 1-2 p.m. We take lunch here, so it dropped back to the 3.5, and after 30 to 60 minutes, it neutralized back, go to 7.5, and then we take dinner, okay, during 8 to 9, 30 to 60 minutes, become up again. So this is how many times the acid attack. Here, number 1, 2, 3. 3 times the tooth in the acidic attack, attacked by the acid. So this one, this is like the previous figure. If the sugar is intake between meals, a few times between meals. For example, this is they already take breakfast, and then they take coffee and chocolate biscuit, and then they take lunch, and at 4 p.m. they take cola drinks. They have a dinner, and there is they watching TV. They take snack and a supper. So there is 1, 2, 3, 4, 5, 6, 7. 7 acid attack in a day. Okay. So the high frequency of sugar intake in a day will cause demineralization of the tooth, because demineralization will occur more often. Okay. So the time between drop in pH is not long enough to recover. Okay, so what is our advice to prevent dental caries? Okay, so patient should reduce the frequency and amount of sugars. Okay, it must limit consumption of food and drinks with added sugars to maximum of 4 times. Okay, so 4 times maximum. So breakfast, lunch, and dinner. Okay, please control the in-between snacking, because once they're taking snacking, okay, in between meals, for example, in between breakfast and lunch, from the lunch to dinner, there is a snacking in between, so it will cause demineralization of the tooth. Okay, so the sugars also should provide less than 10% of the total energy in the diet, or 60 gram, okay, 60 or less in a day for the adults. For the kids, for the children, is half of the total sugar intake of the adult. It's made at 30 gram only. Okay. Okay, next, for the external modifying factors is the role of socioeconomic and behavioral factors. The social factors are closely linked to behavioral factors. Okay, so great number of behavior particularly has behaviors are characteristic and distinctive for each social class. Okay, what is the main of social class here is according to the socio-economic groups. Okay, for example, in Malaysia, current classification is the B40, the M40, the T20. Okay, so there is a different socio-economic group that there is closely linked with their behavioral factors. Okay, so the most investigated social factors related to dental caries is social class or socioeconomic status. Okay, as I said before, the most commonly studied behavioral factors are oral hygiene and dietary habits. That's why when we conduct a study, we ask about their socio-economic status, the background. So we would like to link whether, for example, if we do research about the brushing behavior among kids, for example. So we would like to know their parents' education level, their parents' socioeconomic factors, whether it relate or not. So the socioeconomic status affect our oral health. The poor are more likely to have oral diseases, disorders, and condition. Okay. The poor children are less likely to have dental sealants. Okay. In addition, the poor are less likely to visit a dentist or dental hygienist in the course of a year, because might be they are not afford to go to the private clinics, okay. So and also the parents education level or the awareness. The differential in oral health status between poor and non-poor across the lifespan and major social indicators of the current status of oral health in America today, and provide a challenging baseline against which improvement can be measured. Poverty is also a key indicator for poor oral health status among children, according to studies. Poor children also suffer twice as much dental caries as their more affluent peers. So the children with the most advanced oral disease are primarily found among America's most vulnerable groups, means that the poor, the American Indians, and other minorities, homeless, migrant population, children with disability, and children with HIV. Okay, so if it's untreated, the oral disease in children frequently lead to serious general health problems and significant pain. So it interferes with the eating, overuse of emergency room, loss of school time. So it's estimated about 51 million school hours, okay, left because of dental related illness alone. So as for ethnicity, several studies also have shown highly significant caries difference between racial groups. In Sweden, Wistrom and Nielsen, 1986, it said the findings is the proportion of each immigrant group who visited a dentist was significantly smaller than the proportion of the Swedes. So extraction, endodontic, and dentures were common in all the immigrant groups. Why this? Why this? What do you think? Why this kind of option of this kind of treatment they are chosen by immigrant groups? Okay, because usually the extraction most easiest cheap, the cheap treatment. And once they extract, they have dentures and endodontics. So because when there's a bit decay, it cannot be filled easily. They need look any treatment. Okay, that's why the immigrant have a lot of the treatment needed. Okay, apart from language, cultural problems and low standard of education among immigrants also exposure to new foods usually disturb their traditional eating habits. So therefore, immigrants with poor standards of oral hygiene and irregular use of fluoride toothpaste are at high risk when they come to Western countries. So as for conclusion, the most important internal modeling factors related to dental caries are salivary hypofunction. Okay, some chronic diseases, impact host factors, and unfavorable anatomy of the teeth that favor plaque retention. The concentration in saliva and plaque are closely related to the type of carbohydrate ingestion and the frequency of ingestion. Right. As well as the oral hygiene practiced by individuals. So this figure it shows about the caries balance. The caries process that involve shift in the balance between pathogenic and protective factors. Okay, so there is a pathological factors, there is a protective factors. The red one, the red font, pathological factors, means that once if there is a lot of pathological factors, the tooth become demineralized. Okay, it's like seesaw. Okay, when there is pathological factors become heavy, become a lot of pathological factors, it become demineralized. And there, if there is a lot of protective factors, okay, that protect the tooth, become remineralized. So the tooth become protected. Okay, so it's about the caries balance. Okay, so this is the references for this whole lectures. You may have a look for. Okay, so with that, thank you for your attention. So hopefully you can hear these lectures and ask me during the virtual class later. Okay, with that, thank you and hope to see you all again during our Q&A session. Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh.